should know. We don't do a lot of blocks over here, but I'm hoping to sort of ramp that up and get that going, and sort of the more cases we move here as far as abdominal cases, doing taps, doing pets, I think that it's really just important to have these foundations. And then we'll also talk a little bit about Exparel today. That's the long-acting bupivacaine, long-acting local anesthetic that we use in all of our fascial plane blocks. So anytime we do a tap over here, packet, I know we're doing a few more of those, we'll be using Exparel, and then we use it actually now for all of our peripheral nerve blocks as well. So you're going to see it more often. It's being stocked in your Pyxis, both that we're going to be using and then the surgeons are going to be using. So just wanted to sort of give you an update on that and just sort of a background. Hey, Robin, good morning. So we'll go ahead and get started. Sort of what we're going to do here. So this is basically, we can give you sort of this to put up to laminate. Any place we do a block, there's sort of a specific process you have to go through. And this is mandated by not only by JCO, but also by ASRA, which is the American Society of Regional Anesthesia and Pain Medicine, which is kind of our specialty board. So it's called, obviously a timeout process. In Europe, they call it stop before block, so I thought that was a little bit catchier. But basically, there's things you have to do prior to doing the block, and then after doing the block. So I'm sorry this is a little bit small, but basically, the nurse has to get report, and a lot of this stuff it's just a review. But we do have to sort of keep track of this and actually chart it. So the block nurse has to get the report. The regional anesthesiologist will use the chart, making sure the H&P is signed, updated, consent is signed, updated. All those things need to be done prior to the block because we do sedate the patients and they're unable to give legal consent afterwards. And then every patient has to be on standard ASA monitors. So this is something that might be, new to you guys if you don't do blocks very often, but every patient has got to be on EKG continuous. They've got to be on non-invasive blood pressure at least every 5 minutes. They have to have some sort of monitoring of their respiration, so we use the capnogram, and then they all have to be on oxygen because we do give them sedation. And then what's important for us to ask, and if you don't see us doing it, please let me know because this is, again, one of those JCO mandated things. We have to ask an open-ended question. So, and this comes out of the not doing a wrong-sided block goal. So the first thing I ask, if I go in to see a patient, hi, I'm Dr. Holtz, I'm with anesthesia, I'll be taking care of you today, what are you having done today? All right, not like, hey, we're doing this side, right? All right, that's trouble. So open-ended question, and then we have to physically mark the patient. It doesn't matter if the surgeons mark them yet or not, that's irrelevant to us. I have to physically mark the patient, the side of the block I'm gonna do. Obviously with a tap block or something, bilateral, it doesn't matter.
So that's all before any
This
Versed?
is all before any Versed, correct. So the patient has to be sort of an awake and legal participant in this process. So open-ended question, what are you having done today? We mark the surgical site, we explain the consent process, risk, benefits, options. As of now, we are still covered under the surgical consent, so we don't need to get a separate written consent unless it's on a different day than the surgery, which will never happen here. We do that a lot with our trauma patients over in the main OR. That will be changing. Pretty soon we will have to be getting a separate written consent to do a block. Yay. Yay, yay, yay. And then you guys will drop the medication. So, historically we've used Versed and fentanyl to sedate patients prior to doing a block. We're really trying in this whole sort of combating the opioid crisis thing that we're doing, we're really trying to get away from Versed if we don't need it. So all of our total joint patients, anybody getting just a peripheral nerve block, they just get Versed. And they really tolerate it just fine. For the tap blocks and PEC blocks, we do give a little fentanyl because those tend to be a little bit more uncomfortable for the patient. But I had a tap block here, some of you took care of me, and I had no sedation because I wanted to see how it felt. It's really not that bad. Okay, it feels crampy, that's really about it. But other than that, it's fine. So, ask your anesthesiologist what they want. The old adage of 2 Versed, 2 fentanyl might not always be the most current way of thinking. And so then prior to the patient being sedated, it's very important that everybody participates. So the anesthesiologist, the nurse who's doing the block, and the patient prior to giving sedation. Okay, so everybody has to participate in that timeout. You have to ask the patient you guys know the timeout process, their name, their date of birth, allergies, and what are they having done today. Then you need to physically show the anesthesiologist the consent. Make sure you show them. You guys are going to be sort of my eyes and ears here, making sure my block docs are doing the right thing. But show them the consent and just say, like, I literally will point to it. Okay, left, total knee. Okay, got it. All right. So everybody's on the same page. And then sedation's given and the block proceeds. Now, after the block is done, one of the other things that JCO is mandating is a time out process or a sign out process. So basically all that means is, okay, you put the block in, all right, we just did a interscaling block for, shoulder surgery. No complications, just watch the sats. Because, again, anytime you do an interscaling, you knock out the front end. Or we just did a spinal anesthetic, no complications, just watch the blood pressure. So any sort of little thing, anything that needs to be watched should be in that sign out process. And that is documented as well. Any questions about this? Pretty standard. It's just, just wanted to make sure we're all on the same page with what we have to do by JCO. Yes.
Does the consent have to say block on it with the?
No, it doesn't.
Okay.
It doesn't. The question, do you guys hear? The surgical consent does not have to say block. The surgeons, when they post for a block, we take that as their order that they want a block. And again, that might change when we get our own little consent, but for right now, that's fine. Yay, organic chemistry early in the morning, okay? So local anesthetics, just as sort of a background. Here's their chemical structure. They all have a lipophilic group, they all have a hydrophilic group, and then they have this intermediate bond. This intermediate bond determines what type of local anesthetic you're dealing with. There are two types. There are esters and there are amides. This is important because of certain allergies and certain tolerances to one or the other. The sort of Cliff's Notes version, way to sort of remember it, all the amide local anesthetics have an I in it. So lidocaine, ropivacaine, bupivacaine. It has an I in it, it's an amide. You can go ahead and flip. And this is how they work. So they act on the level of the nerve, okay? So local anesthetics are this very simple, stupid way that we can control pain. They act at the level of the nociceptors, at the level of pain. So instead of giving all these opioids that act centrally and have a lot of side effects, the purpose of regional anesthesia is to sort of block pain at the source, right? So diffuses through the phospholipid membrane, and it binds at the sodium channels, and it basically prevents the influx of sodium into the cell, and that's how it acts on the neuron. Go ahead and. So there are maximum doses that we can use, okay? This is a rough estimate of the maximum doses of the various local anesthetics, and this is in 24 hours, okay? So just kind of important to keep in mind. The anesthesiologist who is doing the block should absolutely know these maximum doses. Where we actually get into more problems is the surgeons who are injecting on the field and might not be paying attention to how much they're actually giving. So it's kind of important for you just to sort of have a generalized idea, so that if something seems a little bit wonky, how much have they used? Confer with your anesthesiologist too in the room. We get asked all the time by the surgeons, how much of this can I use? How much, and you have to remember too that local anesthetics are additive. So you can't use the maximum amount of bupivacaine and also the maximum amount of lidocaine. That's not kosher. It's additive, okay? Go ahead and again, different local anesthetics have different levels of safety. So here's increasing toxicity with maximum dosage. And it's also, so bupivacaine tends to be the local anesthetic that we're most concerned about. And the reason is because lidocaine or bupivacaine, when it binds to the sodium channels, it fairly readily dissociates. Okay, so if they do get some sort of systemic toxicity, that it's out of that system pretty quickly. Bupivacaine binds to that sodium channel and holds on and does not let go. That is why historically it's been a prolonged code process when somebody has bupivacaine-induced local anesthetic toxicity. Now with intralipid, which we're going to talk about, things have changed a little bit, but just so you know, there are different anesthetics are different as far as their toxicity goes. It also depends on where you inject them, okay? So not all sites are created equal. Think about the blood flow to that area. Think about the uptake, the systemic uptake of it. These are where you're going to get the lowest systemic concentration. So if you do a field block, okay, if you do a spinal, sort of in the middle, caudal, epidural, brachial plexus, the highest systemic concentration is the intercostal. So I'm going to be a lot more careful about sticking religiously to that maximum dose if I'm doing intercostal blocks. Okay, so that really happens in the main OR when they're doing a lot of the thoracic cases, but it does happen over here. Dr. Hanna does do intercostal injections for his breast cases. So again, just something to be aware of. That's a very, very high systemic rate of absorption. Those vessels run right with those nerves. They soak up a lot of that local anesthetic, gets into the system. So making sure that he's staying, or whoever is doing it is staying within that concentration allowed. Go ahead and flip. Okay. So, one of the scariest things that can happen with local anesthetics, overall, they're very safe. But there is something called LAST, or local anesthetic systemic toxicity. This can be fatal. So it's important that we recognize it early and that we treat it early. And that we sort of recognize what predisposes a patient to it. So there are certain patient characteristics that predispose to local anesthetic systemic toxicity. So extremes of age, the very young, the very old, low muscle mass, your little old lady who comes from the nursing home. Females tend to have a higher likelihood than males, just statistically. And then comorbidities, obviously anybody with some organ dysfunction, especially heart and CNS. And again, we talked about the characteristics of the local anesthetic itself. So bupivacaine is more dangerous than, say, lidocaine overall in general. We talked about the block site, and then this isn't going to be relevant to you, but the longer we extend the local anesthetic infusion, the higher sort of concentration systemically they get and the higher risk of LAST. This is why when we do an on-Q pump, we typically limit it to about 3 days. And this is why Exparel has been a really great addition to our regimen, because it is so safe. We're going to go over the pharmacokinetics of that. And then I just want to make a note here. So non-anesthesiologists are involved in up to 50% of LAST cases. So, and non-anesthesiologists do a very, very small amount of the blocks. So it's a lot of it probably is education related and just not being aware of toxic doses, not being aware of signs and symptoms, not being aware of how to treat it. So again, I need you guys to be all of our eyes and ears. We're pretty, well versed in this stuff, but there's a lot of other people who use local anesthetics around here. So just important for you guys to be aware. Okay, so this is what we were taught. I don't know if you guys were taught this, in nursing school, but in medical school, this was this beautiful little tied up with a red ribbon way that the patients went through LAST, all right? First, they got a little drowsy. Then they got a little, numbness and tingling around the tongue. Then they got some ringing in the ears, little musculospasm, progressed to seizures, then progressed to respiratory arrest, and then finally went to cardiac arrest. And there was this nice little progression. So you had this, like, oh, okay, I'm right here. I have time to treat it before it gets here. All right, so that's what we were taught. That's what I learned in medical school and in residency. Go ahead and flip. This is what we know now. And this just came out in February of last year in our RAPM, our anesthesia pain journal. So what they did is they took this huge database and they looked at, for 2 straight years, how LAST presented. And what you can see is it doesn't necessarily go in that nice order. 43% of patients presented only with CNS symptoms. 33% had both. 24% went straight to the cardiac. Okay, they didn't have any premonitory neurological symptoms. They went straight to cardiac arrest. And this is the spectrum of cardiac presentations. Sorry, it's a little bit blurry, but dysrhythmias, conduction delay, almost a quarter went straight to just cardiac arrest. They didn't have any of these other prodromes. And then bradycardia, hypotension, which we typically thought was sort of the first sign. That's actually the lowest little pie. Here's the spectrum of CNS presentations. The vast majority present with just a seizure, frank seizure. Some will just completely lose consciousness, and then there's other things. But agitation, which again we thought was this sort of premonitory sign that something bad was going to happen, it's only 6% of patients present that way. So again, this is just making you aware that LAST can look like a lot of things. okay? It can present in a wide variety of different ways, so just always having your suspicion up, always being paranoid. Okay, so how do we treat it? All right, this is like a very busy thing, and I'm gonna go over sort of the Cliff's Notes version in a minute. But basically, if you suspect it, treat it, all right? The second anything seems a little bit kind of like wonky to you, treat it. There's nothing wrong with giving intralipid. The intralipid is the treatment. It is the antidote to local anesthetic systemic toxicity. It's not harmful at all. Maybe don't get your cholesterol checked right afterwards, but other than that, okay, it's not gonna do you any harm. So if in doubt, give it. We give it in the main OR in the block room probably once a year. Now, would those cases have progressed to full-blown last? I don't know. I don't really care. All I care about is that they didn't, because we gave intralipid. So again, the rate of last has gone way down since the intralipid came out probably about 5-6 years ago. And it basically, we don't really know how it works. We historically thought that it sort of bound to the local anesthetic and just sort of created like a sink for it and kept it away from the sodium channels. We actually now think it might have other sort of excitatory effects in the myocardium, et cetera, et cetera. So we don't really know how it works, just like we don't really know how general anesthesia works. We just